Okay, good. Today we're going to start with a rough overview of extremity adjusting. Now this is vital, okay, but first, before you do extremity adjusting, you've got to pay attention to the spine. When you're looking at the human being, carpal tunnel syndrome, okay, which is compression of the median nerve, is a double crush injury, begins in the neck. So if you're not paying attention to the neck, you're not going to correct carpal tunnel syndrome. All rotator cuff injuries, unless the person's been laying down, all comfortable, and somebody beats them in the shoulder, okay, which I doubt happens, okay, the rotator cuff is going to be involved in the neck as well. Why? Because if that heads forward, what's the most common injured muscle in the shoulder? The supraspinatus, and that's the most available for injury if the head's forward. So if you get the typical office worker with a forward head carriage, that's going to choke off the blood supply and nerve supply to the topmost muscle, the supraspinatus, and that's going to cause a weakening of it. Now we're not going to go through a lot of rehab. We're not going to go through a huge amount of muscle testing. I'm going to show just a rough overview how to assess for the problems with the extremities. But first off, you have to look at the spine. Make sure the neck has been adjusted. Make sure the neck has got proper nerve supply. So when you're looking for the sternoclavicular joint, the way to assess this is to put your fingers on either side and come down. And you can see this one here, if you're right dead in the middle, his left SC joint is slightly superior than the right one. So that means it's off. That means this one is either high or this one's low. And how you can check for tenderness to say which one's more tender, 1 or 2. If he says neither one, it might be because he's right-handed, because typically right-handed shoulders are going to be slightly, it's going to be the dominant one, and the dominant one typically presents a little bit inferior. So to demonstrate this, if this one here is low, this one here is high, what your contact's going to be is the superior aspect, and it's going to be more lateral to medial thrust. Now the forearm is going to denote the line of drive. You don't want to drive it down into his rib cage area. What you want to do is gap it. But since we've got this great weight that can distract him, what we're going to have him do is we're going to have him abduct his arm, and when he raises it up, right when it gets to here, or just parallel, with the clavicle, when it gets out in that fashion, we're going to drive it down. You can also assist him by applying pressure, distracting it, and then driving it down as well. Okay? Now, so really, and this is a very, very tender adjustment. What I want you to do, patient, is to raise your arm just like that. Go from here all the way up. And then right when he gets there, bam, you drive it down. If it's an inferior one, raise it up all the way, you'll drive it up in that fashion as well. Okay? So that's the SC joint. For the AC joint, there's a couple of ways to adjust this one. One of the ways, here, have a seat. Now the AC joint, again, this is very, very tender. What you want to do, you're going to contact to assess it, apply pressure on either side, and check to see, because this is a very, very common one. So you draw the clavicle out, compare the right side to the left side. If there's been a shoulder injury, this is going to be a very, very tough adjustment. You may not want to do this, but if you've identified this by tenderness, palpation, what you're going to do is contact the clavicle, not the acromion process. And the clavicle, since the shoulder, or the AC, the way it separates or gets injured is the clavicle comes up and the acromion process comes down. So what you want to do, you're going to drive that clavicle straight down. So you're going to contact with the proximal interphalangeal joint and loosen this up. So what you're going to do, you're going to get him to relax his muscles by letting him support you. And then it's a scissor motion where you drive up and drive down at the same time. So it's just in that fashion. So very, very gentle, very, very quick. This one, on both of his, they seemed a little bit off. So now this one here, I'm just going to apply a little pressure, and the line of drive is going to be down slightly medial, superior to inferior. So it's a very, very gentle pressure. Okay, now go on your back, sir. Now I'm going to demonstrate how you would set a dislocated shoulder, which is very similar to how you're going to check a shoulder too. Now, the way shoulders typically dislocate is anterior and inferior. That's because the clavicle, or the scapula and the labrum, it's set in an oblique fashion angle to the spine. So if you go from the forward to the back, that's why the shoulder is designed to hold a terrific pressure going from the front to the back. But going from the back to the front, it doesn't have any support there. Okay, does that make sense? That's why it typically subluxates or dislocates anterior and inferior. Now, on a typical presentation, he's going to be really scared because this thing is not moving. It hurts every time he moves it. So what you first want to do is assure the patient that everything's going to be okay. Don't worry, we're not going to do any fast motions. And what you're going to do is you're going to grab the arm and you're going to distract the joint. Okay, distract the joint. So distract it, you're going to pull down very, very gentle and slow, and you're going to put your hand in, and it's going to be a wedge where I'm going to drive it in and I'm going to pivot my hand. And what that's going to do, that's going to separate the humerus outside of the joint. And when I do that, I'm going to also rotate this. And when you rotate this, you're going to rotate that humerus back inside of that labrum, because that's where it needs to go. So you're going to distract the joint out, put your hand in there, bend it, and then using this like a fulcrum and lever, and you can almost see that it's separating. And then typically it just falls in place. Grab it with your leg or lock it in with your leg and then move it over like that, and you'll feel it clunk right in place. Very, very easy. And what you want to do anytime the shoulder is dislocated, if it's been dislocated very, very bad, okay, you run the chance of compressing the artery structures or arterial structures and the veins, the nerves. You can compress a lot of that stuff, and that's very dangerous. That's surgery time. So what you want to do, you want to check the pulse, you want to check sensations and make sure that that's not impinged whatsoever. And then again, this right here, you want to leave it in place. You may want to check it over the next couple of weeks, and then also adjust the neck and adjust the rib cage as well. And the shoulder will heal very, very quickly. Okay? A good way to assess a shoulder that's not dislocated but subluxated is you can do the same thing. Distract the joint, apply pressure, and make sure that that's in place. You can also, for a standard anterior subluxation, you're going to pronate the body or pronate the forearm, distract down, apply anterior to posterior pressure, and you're going to bring it over like that, and you'll feel the shoulder clunk down. But you got to do it fairly quickly, and you'll feel the shoulder just kind of click in place. And that's a very, very good, easy, quick anterior adjustment, particularly on workout guys that are concentrating on pecs, okay, because girls like flat pecs. Absolutely, it attracts the females, okay? No, plus it's a fun workout, but what that does, that tends to put more pressure on the anterior aspect of the humerus, throwing it forward. So you're going to see the majority of humeruses are subluxated anterior. Okay, now, let's go over the elbow, okay? This is hugely important. When you look at this, you've got the humerus coming down, you've got the ulnar that hooks over, and it's almost like a hinge. Now, since the flexors attach here, and the flexors are generally stronger than the extensors, in a real forearm, the strength ratio should be 5 to 4. That means the flexors are just slightly stronger than the extensors. However, in modern times, when we're grabbing, pulling, typing, everything else, the flexors may have a 6 to 1 or 8 to 1 or 10 to 1 ratio. That means that the extensors don't work as well. Well, if you increase the pressure on the flexors and decrease it on the extensors, that's going to drop these carpal bones down and put pressure on the median nerve. So where does carpal tunnel syndrome come from? It's a double crush injury beginning in the neck, leading to a muscle imbalance of the forearm. And that causes an increased tone on the anterior aspect of the carpal tunnel area, and that compresses the median nerve. So what we first want to do, if we're going to take care of carpal tunnel syndrome, we have to assess the elbow. And what we're going to do is we're going to do a muscle test on this, and this one's really, really easy to do. Hold your hand flat. and his elbow is rested on my leg, I'm going to apply a little bit of pressure just to check the tone. Hold steady, don't let me push it down. And I'm applying pressure, and I'm holding it there just for a moment to see if the hand shakes, if it's strong, just to test the resistance. Right now, I'm testing triceps, and then what I want them to do, flex your hand down, and then I'm going to apply pressure again, and testing the strength there as well. Now there's a slight bit of fluttering, not really a whole bunch, but there is a slight bit difference in tone there as opposed to there. So what I'm doing, I'm still testing triceps, but what I'm stimulating the flexor epicondyle or the medial epicondyle, and we're testing the joint mechanoreceptors, because if that joint is off, the way the body works out, if that joint's not in alignment, the signals weaken the muscle, so that means the muscle doesn't have the same amount of strength. Now, put your hand back like that, as far as you can, and then apply pressure, hold steady really tight, and that's to test the radius, because this is testing the extensor epicondyle. We're actually testing triceps, triceps, triceps. Okay, so we're testing triceps, but we're stimulating neutral, flexor epicondyle, and extensor epicondyle. And then that'll tell you if that joint has a dysfunction. So when we look at, let's say that he had weakness on the radius or the extensor epicondyle, to determine if the radius, and when you look at this radius comes up and it spins and pivots in a joint. That could have gone forward, or it could have gone back. Okay, it could have gone anterior, it could have gone posterior. It could have even been jammed. Okay, so what you want to do is test the good arm with the bad arm, because if this one here seems more prominent, then it's gone more lateral or posterior. If this one is sunken in compared to the one that's not affected, then it could have gone anterior. So what you want to do, if it feels like a depression here, that means it's probably gone anterior. And when I mean anterior, we're looking at anatomical position. So that radius, if it goes forward or has a depression back there, that means that it's actually gone anterior. When I say posterior, again, we're talking about anatomical position, and that radius has gone backwards. Okay? Does that make sense? So if it's gone anterior, you can hook the head of the radius and just flex the arm at the same time you're going to drive it back, so it only really requires that much pressure. If it's gone posterior, what you're going to do is pronate, distract, and with your thumb, you're just going to apply a little bit of pressure in that direction. You don't want to hyperextend the elbow unless you want to get money from him or he knows when the planes attack, okay? That's something you never want to do, particularly to a colleague, okay? No, it's scary too, I know. If you just want to mess with his emotions, do that a few times. No, but what you want to do to adjust it, you're going to pronate, contact that. Now I'm having my hands to support the medial epicondyle, so my hand is actually supporting the medial epicondyle so that he feels a little bit more secure, as well as I'm not going to run the risk of hyperextending it. So he knows I'm not going to hyperextend the elbow, and he knows I'm not going to injure it, because if he is scared, see the muscles tighten up? Yes, he can't stop that. So what I'm going to do is pronate, support the medial epicondyle or support the humerus, apply a little bit of pressure, and it's that much pressure. There's also an alternate, and the alternate, if it's gone posterior and it's a fairly large human, you can pronate again, support it, let it rest, and just do a small impact just like that, and that'll drive it forward. Okay? Now the ulnar, so to assess the ulnar, it will be neutral to assess, and we're going to test the flexor epicondyle, apply pressure, it'll be weak or shaky. Most of the time, it's gone medial because the flexors are generally stronger than the extensors. So what you're going to do, you're going to supinate, distract out, and you can see here's the medial epicondyle of the humerus. So what you want to do, your thumb's going to be on top of that. Again, it's going to stop you from hyperextending. You don't want to line to drive in that direction. What you want to do is drive it straight down or straight across. So if you look, here, support your arm up like that. So if you look, here's the medial epicondyle and the lateral epicondyle. So that's where the humerus is. So our line of drive, if you think about, it's just like a hinge where the ulnar goes right over that. We're going to drive it right along that hinge, okay, or right along the flat part, okay, of the humerus. So I'm supporting that. My medial interphalangeal joint will contact that olecranon process of the humerus, supinate, and then drive down, so it's very, very, very easy. Okay. I know, I've been wanting to adjust that since we assessed it. It was driving me crazy. But and typically you'll get an audible, rarely, and we're talking less than 10 out of 100. It'll go lateral. And what you want to do on a lateral is the same thing. You supinate. I always, again, support the medial epicondyle with the thumb, so he's not afraid that I'm going to hyperextend. And it's a lift up where you hook it with your hand and you just pinch it. Okay, just in that fashion. I'm not going to do it because I just adjusted it medial. Okay? And then, here, let's sublocate it and just try it again. No. We don't do that. As much fun as that would be. Okay, so then to assess the wrist, what you're going to do is you can palpate and check. The lunate is the most common bone that's subluxated, and the way to distract that and to set it, remember, you've got a whole bunch of nerves on the inside here that if you push in, it's going to cause some discomfort. But if you have a wider contact and distract the joint. So my hands are going to be here, and I'm literally going to separate the wrist in that fashion to where it's very, very easy to set. Typically, the lunate is going to go anterior or in that direction. Occasionally, it'll go posterior. A posterior aspect, and you'll get that on just palpation. It's better to distract and palpate to see where it's gone. If it's gone anterior, you distract, have a contact that's wide, and just impulse up in that fashion. It doesn't require much pressure. If it's gone posterior, you can contact, back it up, distract out, and apply a little pressure, and it'll set right in place. Very, very easy to do. The scaphoid is super easy to correct, and that's the most commonly fractured bone in the body, so make sure that you test for tenderness in the anatomical snuff box, because if that baby's fractured, you don't want to adjust it. But if it's just tender with no evidence of major trauma, there's no bruising around it, because that is the first sign of seeing a fracture, what you're going to want to do is put your thumb in the anatomical snuff box, back up the thumb, so the line of drive is going to be straight down in that fashion, and that's going to gap the scaphoid and actually open up that elliptoid joint of the thumb. So it's very, very easy to do. Then, yeah, can you sign for that one? Okay, now, to assess the phalanges, here, put your hands together just like that. What you can do when you're looking at the phalanges, look at the nail beds. You can see this nail bed is rotated in. This one is slightly rotated in that fashion. This one's fairly neutral, and this one's slightly rotated in that direction. So what you want to do is understand that he's using his fingers all day long. Since this one's internally rotated, we want to derotate it out. So I'm going to grab it with my fingers, and when I rotate, or when I just curl my fingers, see how it rotates out that finger there? So grab it like this, just curl my fingers just in that fashion. That's going to derotate it out and distract it, so it's just in that fashion. So it's very, very, very gentle. Since this one was rotated in that direction, and it derotated out, just a little bit. Yeah, I know, it doesn't hurt. Don't be scared. I haven't hurt anyone yet. Okay, good. That's the upper extremities. Now, first off, before we go to the lower extremities, I'm going to demonstrate the greatest exercise ever, rubber bands. So now this, just throw them around. Go on, just act like they grow on trees. The number 32 rubber band is my favorite. Why? Because it pretty much hits most every arm around. Okay, it's absolutely perfect. So what you want to do, again, let's say he has a muscle imbalance of the forearm, like he does. Okay.
How do you tell?
Huh?
How do you tell?
Look at the body structure. He obviously works out. He's working the flexors. There's not a hell of a lot of stuff at the gym that works the extensors, is there? Mm-hmm. I know. So you look at the workout body, you know he's muscle imbalance. You look at the office worker, you know there's a muscle imbalance. Okay, and then if you look at the base of the neck through an x-ray, you can actually see where's the most common area of degeneration? C5, C6. Okay, that's right at the top of the brachial plexus. So if you have an impingement in the neck, that's going to lead to a loss of function of the forearm. Now, here's a little clue. Since carpal tunnel syndrome is a double crush injury beginning in the neck leading to a muscle imbalance of the forearm, how do you make a muscle imbalance worse?
Do more flexion.
No, you brace it. Oh, okay, good. So this is what you can do. If you see somebody wearing a brace for carpal tunnel syndrome, try and find some electric tape in there too. If they're wearing a brace for carpal tunnel syndrome and they haven't checked the neck and they haven't done any exercises to adjust the forearm, then there's going to be a muscle imbalance that you've got to correct. So what we're going to do is how I talk to the patients. Put your hand like a flower bud, then you're going to make it into a claw like you're going to scare a small child. Flower bud to claw. And you're going to do it with this. Okay? So here, go ahead and make a claw. And when you're doing it, the fingers should come out all even, and they have to be a claw. If somebody does it like this, no, we're not waving at people. Okay. Okay, it's close. Okay, not like this. It has to be a claw. Because what happens is, what we're using the extensor digitorums, okay? These extensors go underneath an extensor retinaculum. And what that does, since there is a muscle imbalance of the forearm, typically on carpal tunnel syndrome, we're increasing the tone of the muscles on top of the carpal tunnel itself. And what that does, that tends to pop it up. Okay, because when you take the skin off of the body, you see there's an extensor retinaculum and a flexor retinaculum. Oh, bummer. You know what? Let's get some Scotch tape. It's in the top drawer on the right. So the exercise is to do this till fatigue. Okay, and this means once you get tired, guess what you got to do? You got to do it again. Once you get tired, you got to do it again. Okay, so this is going to be the extensor exercise to correct it. Now, let's say he has trouble sleeping at night because the pain is so great in his hand. Ideally, you would use electric tape. I don't have electric tape. This is not my tape dispenser. Okay, this is my crew's tape dispenser, but I'm confident enough, man, that I could use this tape dispenser. Okay, so what we're going to do, it should be electric tape. Electric tape is easy, it's flexible, and it doesn't stick to fur. Okay, so it's like absolutely ideal. And what you want to do, if somebody has extreme pain and they can't work the hands, you know, it's going to be about a week and a half to get them out of discomfort. So what I want you to do is put your pinky and thumb together, okay? Hold steady like that. Hopefully this is not Scotch tape. Hopefully it's electric tape. And what you're going to do, you go right around the base of the metacarpals, okay, and tape it, okay? Then go ahead, you can just relax. Okay, and what this does, going around the base of the metacarpals, not the carpal bones, not the wrist bones. You want to go off the base of the metacarpals. This maintains that tunnel. I'd wrap it about 3 or 4 times, and then that way it maintains the integrity of that tunnel, takes pressure off the median nerve, and then he can go about working, everything else. But use electric tape, because it's cheap, it's something that he can use, and then that way he can go throughout his day, he can sleep without pain, and it does take about a week and a half to get someone out of carpal tunnel syndrome pain. Okay, and then say throw away the wrist brace, fire the guy that gave it to you. Okay, so that's upper extremity. Okay.